Thank you for the confirmation. Welcome all to yet another meeting, Friday morning meeting at the Fetal Medicine Unit. Dr. Verenga has been taking us through a series of prenatal diagnostic tests in fetal medicine. And today is going to focus particularly on prenatal diagnostic test result interpretation. So without further ado, can Dr. Verenga please start screen sharing? Dr. Verenga, can you start screen sharing?
Yes. Morning, Dr. Fletcher. I'm on it. I'm on it now.
Okay, thank you.
It's coming.
A few housekeeping issues, perhaps, as he tries to start screen sharing. Can we please all be on mute as we listen to his presentation? If we have any questions or queries, we usually take them at the end of the meeting. So please write down your questions either in the chat or somewhere you can note them down, and then you'll be free to ask them at the end of his presentation, unless invited to ask questions before the end of the presentation. Thank you.
Good morning, colleagues. Thank you so much for taking your time to attend yet another meeting on prenatal prenatal testing and diagnosis series. This morning, we'll be focusing on the interpretation of the results. One of the reasons why I thought was very important for us to oftentimes I get calls from colleagues. We have results before them. Sometimes it is very difficult to make sense of the results. Two, very difficult to also explain to the one thing which we have to acknowledge is that prenatal test results, if they come back as normal, cause what I may call unprecedented stressful situations to the expecting couple. I've come up from the physician's world, from the gyne side of things, and also even from the surgical side of things, where the patient may be told of their results, but there's nothing as stressful as prenatal test results, being told that the results of your baby are somehow wrong. So this causes a lot of stress, and this stress is doubled if the doctor cannot of those results or cannot satisfactorily explain the results to the patients in terms of what it means and what does this mean for the baby and the care of the pregnancy. So it is from this background that I thought it is very important that we discuss some issues to do with the actual handling of the results when they come from the laboratory. I think the admin guys, do you want to quickly admit people as they come in, because I think you are taking a lot of time to admit them and they're interrupting the screen. The admin guys, please admit people as they come in. Right. So before I go there, because I know there are some colleagues who probably are joining for the first time who were not in the initial talks, I just want to highlight some issues which we have to take cognizance of. The a priori risk of Down syndrome varies with maternal age, so that at 35 years, it is 250, 1 in 250, the probability of having a baby is Down syndrome. So it is because of this risk that led people some 50, 60 years ago to start defining this maternal age as kind of a cutoff to say when do they stop or start offering Down syndrome screening. So, however, if you look carefully again, you see that the risk for Down syndrome decreases with the gestational age. So that when results for Down syndrome are being reported, we want to know what is the risk referring to. Our own application, which we use in the fetal medicine units, allows us to pre-modify it, to tell the application to tell us to calculate for us the risk at the gestation age which we have seen the patient, or to tell us the risk at term. So whenever you come across a result, you want to know the result for the risk, this risk or this probability for Down syndrome. Are they reporting the risk at the gestational age the patient was sent for screening, or they are reporting the risk at term? Because the risk for Down syndrome at term is lower at 40 weeks as compared to 12 weeks. The reason for this is that about 20% of babies with Down syndrome, they either miscarry or they have intrauterine fetal demise. As a result, the total number of babies who can potentially reach term is much less in Down syndrome. So it's important to remember this. And also to remember that as the woman gets older and older, the a priori risk continues to deteriorate. But however, we do not base our screening program based on the a priori risk. So you are not going to send a woman for a diagnostic test because she's 40 years, because her risk is 1 in 70. You are not going to do that. Because this is the a priori risk. What we need is the a posteriori risk, which we have to calculate. Just a recap of this slide one more time, that when you are interpreting the results, you want to know that the risk that has been quoted, is it the risk for that particular gestational age which is screened, or it is the risk at term? Because there is an option for all the Down syndrome risk calculators to give you the risk at term, to say if this pregnancy goes to term, what is the probability that this baby will be born with Down syndrome? So that risk decreases with gestational age, because about 20% of babies with Down syndrome either miscarry or have intrafetal demise. They don't go all the way to 40 weeks. If we go to the next slide. Next slide. So the next slide, we have trisomy 18. Sorry, I doubled there. Trisomy 18, trisomy 13, and monosomy X. But if we just look for trisomy 18 and 13, after removing monosomy X, the picture is slightly different from the Downs. These conditions, because the probability or the a priori risk depends on the background risk of a population or the background risk of the condition. Trisomy 18 is probably 2.5 times less common than trisomy 21, while trisomy 13 is 7 times less common than trisomy 21. So because of that, you see that the risk at 35 weeks is 1 in 600, and the risk at for trisomy 13 is 1 in 1,800 at 35 weeks, because these conditions are less common than Downs. So again, you will see that for trisomy 18 and trisomy 13, the risk at term is way, way much less than the risk of 12 weeks, because about 80% of babies with trisomy 13 and trisomy 18, they either miscarry or have intrauterine fetal demise, because these conditions are lethal. At trisomy 18 are more lethal than Downs. So because of that, we see this kind of a trend. So again, when you are interpreting the results from the laboratory, you want to know that the risk that is being reported, is it the risk at the gestation age at which you have calculated, or it is the risk at birth, at term? And to just remember that trisomy 21, 18, and 13, the risk changes with maternal age, while that for monosomy X, which is tenuous, it remains constant. It's not affected by maternal age. Risk cutoff. For us to say somebody's high risk or low risk, we are referencing to a specific value of a cutoff. So when the results come, it is this specific value that we look at and tell the woman that, look, you are high risk, you are low risk. The first question is, how do we then determine the risk cutoff? The risk cutoffs vary from nation to nation. Some countries use 1 in 300, some use 1 in 500, some use 1 in 250. We are using 1 in 100. If you ask me why we are using, of course, I'm going to explain from this table here why I support the idea which you are doing at the moment of using 1 in 100. But of course, we are influenced by Britain. In the UK, they use 1 in 100. So when I came back, I also said, let's use 1 in 100. I spoke to Professor Mjanja. He has been using 1 in 100. So, but I will explain the logic and probably why I think it is good that we are using 1 in 100. Let's assume that we decide to use 1 in 50. That is a cutoff of greater than 1 in 50. If somebody comes as 1 in 60 risk, we told them that you are low risk. If they come as 1 in 30, then we told them that you are high risk. What will happen to the people we are screening? So out of a population of 75,000, let's assume that we have screened 75,000 women. Out of these 75,000, about 1.5% of them will be classified as high risk. So 1.5% will be classified as high risk with this. And then out of this, which you have classified as high risk, out of this 75,000, 1% of them, if we do a diagnostic test, there will be no more babies. If we follow up the result of the high risk, then we do a diagnostic test, then 737 or 1% of the population of this 1.5 will be classified as no more babies. There is no Downs, there is no Patel, there is no Edwards. Then the abnormal cases, 71.9% out of the 391 here, will out of the 544 that will be abnormal, we will have 72% with trisomy there. So in other words, the 72% of Downs will be picked by this method. We will pick 72% of the Downs if we use 1 in 50. So what is the trend? The trend we learn is that as we increase the risk cutoff, what we are going to see is that we are going to increase the pickup rate of Downs, of aneuploidy, not Downs, but all the aneuploidy from trisomy 21, 18, 13, and the others. We are going to increase the pickup rate so that if we use a risk cutoff of 1 in a 5,000, we will nearly pick all the cases of Downs in a population if we use 1 in a 5,000. But here is the trade-off. So the higher your cutoff, the more the women you are going to be subjecting to an invasive test. So you can see that for you to achieve a 100% detection rate, you are going to find yourself doing invasive tests in almost more than 50% of the women who will turn out to be normal. More than 50% of your invasive tests are going to turn out to be normal. remember, the invasive test comes with a miscarriage rate. Of course, we said it is very low, less than 1% from last week's presentation. But if you take in the numbers, even a 0.1% of 47,107 is quite a lot. So this therefore means that if we choose a cutoff which is trying to pick up as many, we are also going to increase what we call the false positive rate, and we are going to have more invasive tests than are necessary. So why are we using 1 in 100? Because we are using this one. Of course, the whole idea is to try and achieve this balance, to say we want to reduce the number of unnecessary invasive tests, at the same time having a modest detection rate. So in other words, with the 1 in 100, we'll probably pick 80% of the babies with Down syndrome, with probably an invasive test rate, a false positive rate of around 2% there, if we use the 1 in 100. Of course, we can still use 2%, we can still use 1 in 150, we can still use 1 in 200. The more we increase this value in trying to achieve a higher pickup rate, we also increase the number of invasive tests that will come back as normal findings. There are other determinants. For those countries that have a national screening program, there are other determinants of why people end up choosing this kind of test, because invasive test is very expensive to do an invasive test. So all those factors come into play, and probably this is one of the reasons why England in particular chose this, because it's a national health funded program where every cost has to be taken into account. So we are using 1 in 100, but always remember that the risk of an individual is interpreted individually. Someone may tell you that 1 in 150 is good enough for me, doc. I'm a risk taker. Don't you do anything on me? Someone will tell you that, doc, that risk of 1 in 150 is too much for me. I'm not a risk taker. Let's do further tests. So, but for public health policy, this is how the risks are determined. You say, well, how do you come up and say 1 in 100 is our cutoff, or 1 in 150, 1 in 200? Because when you read your books, especially for our registrars, we are going to see some saying we are using 1 in 300, some 1 in 200. You need to know how it comes about. Say, this is how people determine, to say, can we afford a lot of unnecessary invasive tests while trying to increase the detection rate, or we can accept that we may miss some babies with Down syndrome, but controlling the invasive rate and also the complications that accompany invasive testing. This is to just illustrate the point which I made there, that if we are using this kind of a risk for the same population which Professor Nicolai studied there, this is what you are getting, that for abnormal fetus per 1,000 invasive tests, if we use this cutoff rate, you are going to pick 228 abnormal fetuses per 1,000 invasive. But you can see the moment you begin to increase your cutoff rate, look at the numbers we are picking for each invasive test. So in other words, you are going to do 1,000 invasive tests to only pick 30 if you use 1 in 200, and you are going to do 23. You are going to pick 23 to only pick 1,000 to pick 23 if you use 1 in 300. If you use 1 in 500, it becomes even more weird that you are doing 1,000 amniocentesis and CVS to only pick 4 cases of Downs, Edwards, Fetal, or other trisomy. So this is the logic. This is why we think it is reasonable for us to use 1 in 100 as a cutoff. This will become important as I explain the results from the lab, because I also receive patients whom the lab is causing a lot of panic, because the lab is doing both the laboratory people and the clinicians. They are actually sent direct, they call the patient and tell the patient that you are high risk because your risk is 1 in 150. we are having those kind of experience where patients actually come in tatters, being totally destroyed with the laboratory. Yeah? The importance of understanding this risk. Then we have a situation, we have sent your patient for 11 to 13 week scan. Then during the scan, one of these abnormalities is picked. You have you want to offer your patients combined tests. So if aneuploid is, if anencephaly is picked, you pick up any anencephaly, you don't go on to do a combined test. Anencephaly is rarely associated with chromosome abnormalities, and it's a lethal condition, so you don't go on to do combined tests. It's not going to change, one, the counseling of the pregnancy and the management of the pregnancy. So if anencephaly is detected or acrania is detected, then you stop. You don't go on to say, let's do a cell-free DNA, fetal cell-free DNA, or a combined test. And we do not offer invasive tests for a baby with anencephaly because it's rarely associated with chromosomal abnormalities. And we know that the recurrence risk is counteracted by giving folic acid. Then in another situation, a holoprosencephaly may be detected. Holoprosencephaly is a condition where the baby fails to divide in the normal way, and we have a univentricle instead of the usual ventricular system. We just have a univentricle in the front, and the baby fails to divide. There will be a missing midline for these babies at the level of the BPDH circumference plane. The question now is, what do we do? You had sent the patient to do a nucleus scan so that you can offer combined tests. Because studies have been done with holoprosencephaly, with invasive tests being done by the Fetal Medicine Foundation. And we've seen that in the presence of a holoprosencephaly, the risk of having trisomy 13, which is Fetal syndrome, is 1 in 2. If the baby has holoprosencephaly, the risk of having trisomy 13 becomes 1 in 2. So that means you don't go on to do, one, the combined test. You don't go on to do fetal cell-free DNA test, but you jump straight to do an invasive test to confirm, because this has an impact in the recurrence risk and the counseling of the woman for recurrence risk. So if a major defect such as holoprosencephaly is detected, you don't go on to do a combined test, neither do you do a fetal cell-free DNA test, but this woman is referred for an invasive test so that we certify whether there's trisomy 13 or not. If it is not, then the counseling for recurrence risk has to be different, because it depends whether there's a genetic syndrome, whether there's trisomy 13, whether there's a non-association in terms of how we are going to counsel the patient. Then if a diaphragmatic hernia is picked, then the risk for trisomy 18 becomes 1 in 4. Irrespective of what the nuchal looks like, irrespective of the nasal bone, irrespective of anything else, unless if there's another major defect, but the risk becomes 1 in 4. So you don't go on to do a combined test, you don't go on to do a fetal cell-free DNA test. What this baby needs is an invasive test, amniocentesis or CVS. That is what you have to do. AVSD. If AVSD is picked in first trimester, the risk for having trisomy 21 is about 50%, which is 1 in 2. So these babies, we don't go on to do a combined test. We don't go on to do a fetal cell-free DNA test. We do we do invasive tests. Then megacystis. Megacystis is a bladder which measures more than 7 millimeters. The risk becomes 1 in 10 for trisomy 18 and 13. So in this case, you don't go on again to do the combined test or the fetal cell-free DNA test. what the patient needs, because the risk is already high. The risk is not going to be modified by doing the combined test, neither by doing fetal self-DNA test. We need to go on and do the diagnostic test. So in other words, in the presence of a major marker, we don't proceed to do a combined test. Neither do we go on to say we want to offer the woman fetal self-DNA test, because the two of them are screening tests. What we have to do is to offer a diagnostic test. The screening strategy. Of late, results from the laboratory have confused quite a lot. There is something which is being reported as intermediate risk, which has confused practitioners. Well, sometimes you get a call and people say, look, my patient has come back and they have an intermediate risk. What is this intermediate risk and what is it I'm supposed to do with the patient? So the intermediate risk is something that has been pushed since the introduction of the fetal self-DNA test. It is one of the, because when you are screening, each country or each people have to have their own screening strategy that fits into their context vis-a-vis the issues of health economics, to say what is it that your country can afford, that your country can fund. This applies to So what's the whole logic around it? The whole logic around this is to try and address the issues that have come from the first slide, from this slide here. We know that with the current risk cutoff, it is possible that we may miss some babies with Down syndrome. But these babies are a very small proportion of the Downs. So because of this recognition, so if we come up with what we call an intermediate group here, whereby we say those who are high risk will be 1 in 500, then those who are between 101 and 500 will fall into the intermediate group. Then we are going to have this low risk population. So what do we do with this low risk, with these groups? What we do is that if we is the cutoff for high risk, and we offer the women self-DNA tests as a first line before the invasive, we are going to offer about 5% of the population self-DNA tests, because they are the ones who come back as high risk if we use a cutoff of 1 in 100 of the pregnant population. And we will probably pick up close to 90% of babies with Down syndrome. Them for fetal self-DNA tests, and they are negative, which means all they need is a sonography at 20 weeks, and if they are positive, then they go for chorionic villus sampling. But however, there are certain women who have so much higher risk, like those who have 1 in 10 and below. These women will probably deserve to be offered chorionic villus sampling because the risk is just too high. So these women will need chorionic villus sampling instead of offering them fetal self-DNA tests. Then the intermediate group are those who will be between 101 and 500. And if we use this intermediate group, then we will probably offer 15% of the population of the women we see self-DNA tests, because they'll come back falling into this category. And from there, if we offer them fetal self-DNA tests and it comes back as negative, then all they need is another scan at 20 weeks. And if they are positive, then they go for chorionic villus sampling. Then this is the low risk population. This is greater than 1 in 500, in 1,000, sorry. So what is this table trying to do? What we are trying to do is we are trying to increase the pickup rates for Downs. Because we realize that if we just use the 1 in 100, there are certain babies with Down syndrome who will be missed by this risk cutoff. And we are also trying to manage the cost of the fetal self-DNA test. Instead of offering every woman the fetal self-reading test, which costs about between 500 and 600 in Zimbabwe here, US, we can decide and say, let's come up with an intermediate risk group so that it's only these women who fall in this category that we may consider offering fetal self-reading tests. And those below, we have a risk greater than 100, we just have to offer them straight an invasive test. So this is what the intermediate group means. It's unfortunate that sometimes it's being pushed more by commercial companies rather than the clinicians, like in our situation whereby the laboratory started reporting it without clinicians having an idea of what intermediate risk means. So these are some of the challenges that we see with our disconnection between the laboratory and the clinicians, where there is no cohesion. Everyone just moves on without telling the others that, hey guys, we are moving on. Right, pathophysiology of increased knockout translucency. Knockout translucency does not only increase in babies with Down syndrome, it also increases in babies who have a cardiac condition. When there's a cardiac dysfunction, then in babies we have venous congestion in the head and the neck, which may come as a result of neck masses or thoracic masses. Then we also see it in babies with altered composition of the extracellular matrix, and in babies we have failure of lymphatic drainage, as we see in babies with Turner syndrome. Then it also occurs in babies with fetal anemia and in fetal hypoproteinemia and fetal infections, such as with the torch group of infections. It is important to recognize this because it will come into play when you read the results. Then PAPA, this is a recap for those who attend the phase. But I want you to take you to just this last point, and also probably these last 2 points, that the values of 0.5 moles are characteristic of trisomy 21. So that means PAPA is lower in babies trisomy 21. It is almost half the normal range. Then PAPA is also reduced in the following condition, which is trisomy 18 and 13, triploidy, fetal growth restriction, preeclampsia, and preterm birth. This therefore means that if we see a low PAPA, even in the absence of Down syndrome or trisomy 18 and 13, the baby may still have these other conditions. Fetal may be at risk of these other conditions, that is fetal growth restriction, mother developing preeclampsia, and also risk of preterm birth. Then for the Beta-HCG, it doubles in babies with Down syndrome, so that moms of around 2.0 are characteristic of Down syndrome. It is reduced in babies with fetal growth restriction and preeclampsia. Let's interpret this result. This is the result from our laboratory. The interpretation of the Down syndrome results is affected by these factors highlighted here. That is the history of smoking, the maternal weight, whether previous baby with Down syndrome or not, then the number of fetus, whether twins or singleton, then of course the crown rump length, whether IVF was done or not. If IVF was done, we want to know the age of the eggs. If they were frozen eggs, we want to know when they were frozen. Then we calculate, because the age of the egg continue to grow. If you freeze your eggs 5 years ago, it doesn't. That age when they were frozen is very important to supply when you are calculating, because it affects the. That is what we look at, the age at which the eggs were extracted in terms of the calculation of the risk, not necessarily the maternal physical age in the case of IVF. So it is important to supply that information. Then it also depends on the CRL and also the, then we come to the ultrasound scan markers, that is the knockout translucency. What you can see is the absolute value, then the mom. So the mom is very important to look at the knockout translucency. So when results come, you want to check this mom. Normally, it is abnormal if it is close to double the mom, that is if it is close to 2 multiples of median, then you know that your knockout translucency was very abnormally high. Of course, the knockout translucency, like we said before, that you always have to measure it nomogram of the CRIL. So you have to look at this and say, what was the mom of the nuclear translucency? If it was less than 2, or okay, close to 2, normally 1.5 and above multiples of median, we would consider that to be contributing a lot to the overall risk. Then we have the free Beta-HCG here, and again, its mom. It is these values that are of greater importance in interpreting. I've already told you that in babies with Down syndrome, the mom of the Beta-HCG is going to be double. That is, we are likely to have values of 2 and above in cases where you have Down syndrome. Then as for papier, you are likely to have values of 0.5 and below. So in babies, what is the typical picture of a baby with Down syndrome? Of course, they vary from baby to baby. A baby with Down syndrome, the risk may be high because the nuclear translucency is way, way greater. It's more than 2 multiples of median. The baby may come out as high risk for Downs. Then in another situation, you may have a normal nuclear translucency, but the Beta-HCG may be more than 2.2 multiples of median. You may see a value of 3 multiples of median or 4 multiples of median, and the risk will come back as high risk. The same with papier. You may have normal nuclear translucency and normal free Beta-HCG, but you may have a papier of less than 0.2. Why is it important to analyze the individual parameters which we use in the calculation of the risk? If I do have a baby who otherwise is a normal, like this baby is fairly normal, this is normal biochemistry. I do not expect biochemistry to contribute a lot to Down syndrome risk here. I expect this value to probably lower the likelihood of Down syndrome on this baby. But if then it comes back here and have a nuclear translucency of 4.5, and the mom is probably 3 multiples of median or 4 multiples of median, how I handle this result is totally different from somebody who has a higher risk because the mom, the papier is 0.2. What makes the difference? What makes the difference is that I've already told you that the nuclear translucency is not only increased in babies with Down syndrome, but it is increased also with other abnormalities. So that means besides doing an invasive test to rule out Down syndrome, I also have to do a thorough evaluation of this baby for cardiac defects. That means this baby will need a fetal echo. The baby will also need screening for other defects such as congenital diaphragmatic hernia and all the other bed defects, because they are more likely to be associated in a baby with such a high nuclear translucency. This is totally different from a baby who comes, the papier is just 0.2 and the overall risk is high. Then this is totally different. I do not have to, for example, this baby here, I don't have to book this baby for a fetal echocardiography because the nuclear translucency is normal. So interpretation of the result is not just going to the risk, but it is also reading these actual parameters individually. Then let's take, for example, a baby with a papier mom of 0.2. This baby may be reported as low risk. Even if this baby is reported as low risk, what is it I'm going to tell the woman? I'm going to tell the woman that, look, this value called papier is a placenta protein. It tells us information about the placenta, how well the placenta functions. If it is low, it may mean that you have a small placenta, and this small placenta is likely to predispose you to having a small baby and also developing high blood pressure and pregnancy, which is preeclampsia. Hence, I will need to monitor this pregnancy, looking for evidence of both preeclampsia and evidence of small vaginal age. So that means this woman will need to have growth scans done to her and also BP checks more regularly, irrespective of the fact that the Down syndrome result is low risk, because we know that papier is associated with the high risk of a very low PAPA with high risk of FGR and also preeclampsia. The same applies to a very low Beta-HCG. So it is not just the risk which the laboratory reports that we have to look at. We also have to look at the individual markers. Then this is the same patient. This is a different patient, right? One of our different patients there. Look at this result. Nuclear translucency 2.2, 1.6, probably normal, less than 2 multiples of median. I'll consider it to be okay for this crown rump length of 65. But when you look at the Beta-HCG, it's 3 multiples of median, way more than 2. PAPA is fine. A high PAPA just means that the placenta is good. So if we look now, the woman has been flagged as high risk. And how is this risk high? What has modified the risk? So just age and NT, it was 1 in 50, probably because the age, look at the age of the woman there. Then the biochemistry, 1 in 60. Then NT and biochemistry is 1 in 50. Because the mom is so high for this woman, for the Beta-HCG. And overall, if we put in everything, including the nasal bone and ductus venosus, because we do ductus venosus, but the lab doesn't interpret the trachea regurgitation, which you also do. So this is the overall risk. So this woman was flagged as high risk based on this finding. Of course, we canceled it because we are using a risk cutoff of 1 in 100. So we canceled the woman containing this risk. And eventually for this specific patient, she eventually decided not to proceed with the invasive test after canceling the risk modification from all the markers. Was the final risk using our application is 1 in 150. Because we have to put in everything for the combined test to increase the detection rate and also to lower the false positive rate. So this is how we read the result. And the result which you want is this result. We don't read these ones because the detection rate gets better when you put in more markers in the screening algorithm. So this is the patient's final risk, 1 in 150. Not this, not this. But our laboratory, of course, they will panic and they will call the patient and tell the patient that you are high risk, and the patient will also panic and do all, and call their doctor and say, look, the laboratory has called me high risk, what do I do? Right, then we go on to the fish results. When you get results from fish, so this is fish, fluorescence in situ hybridization, we normally get these results within a week, we'll have obtained the results compared to the culture results. So this was the result from one of our patients, chromosome 13, no aneuploidy, chromosome 18, no aneuploidy, chromosome 21, no aneuploidy, and sex chromosome, no aneuploidy. Then this is the conclusion, no aneuploidy was detected for chromosome 13, 18, 21, and the sex chromosome. Gender of the fetus was male. In view of the presence of maternal blood in the amniotic fluid sample received, this result should be treated with reserve. Cytogenetic analysis is expected to confirm these findings. All right, so when we were discussing invasive tests, we said sometimes when you are doing the procedure, you should always remember to discard the first 1 to 2 mils of your sample so that you remove the maternal cells. And I want to admit that on this patient of ours, we did not do it. So this is why this result came like this, but the culture is since confirmed that there is no aneuploidy. So remember, during amniocentesis, the first 2 mils, 1 to 2 mils have to be discarded so that we do not include maternal cells that we sort of purchase as we go in from the maternal skin to the amniotic fluid. Then the cytogenetic analysis is expected to confirm these findings. So that means the fish results are preliminary kind of findings. When you are counseling the woman, we have to tell them that the test did not find trisomy 13, did not find trisomy 18, did not find trisomy 21 or sex chromosomes abnormalities. However, a full result is still pending, and a full result may find trisomy in other chromosomes which were not covered by the fish. Remember, fish, we said it's a targeted analysis. It's not going to pick trisomy 9. It's not going to pick trisomy 14 or 16. But a full chromosome analysis is going to tell us that, look, guys, there's trisomy 14, or there is triploidy. So the results of the FISH are not final results, and do not tell the patient to say your baby does not have any form of chromosome abnormality. Just tell them that the targeted trisomy 13, trisomy 18, trisomy 21, and the sex chromosome abnormalities are not there. But we need to wait for the culture results, which should normally come back. Now, this is the final result from the Karyo now, from the culture. So this is the culture after 14 to 21 days, the results come. This one came in what? Almost 21 days, right? Cytogenetic analysis of culture amniotic fluid metaphase revealed a model number of 46 and a 46XX karyotype in 10 cells. They have to tell you the number of cells that they have looked at, because if they looked at the fewer number of cells, they may miss mosaicism. Like we said last week, that mosaicism is fairly common. So it is important that they describe the number of cells that they have looked at. No gross structural abnormalities were detected in James Abedi metaphase. And the above findings is characteristic of a normal male chromosome. So this is how the results for an AMNIO will come like. And of course, they will write that this confirms our previously reported AMNIO PCR. In this case, they did a PCR, not FISH. They are almost the same procedure, PCR and FISH. They are all targeted kind of tests. Right. Then we may have these kind of situations. We have done your AMNIO, then the result may come back like this. What does this mean? There are two possible scenarios that may produce this kind of result. This was one of our patients. In this case, the sample took 1 week to get to the laboratory. I don't know what happened in the transport chain, but it took 1 week to get to the laboratory, and the amniotic fluids, the fibroblasts, which are within the amniotic fluid, all died. So by the time the sample reached the laboratory, there were no cells to analyze. This is one scenario. Then if you do amniocentesis in women who probably have ascites, or if you happen to take maternal urine, sometimes if the bladder is too full and you are not well versed, you may take fluid from the maternal bladder, which may have very few cells from the bladder or no cells to culture. So you always have to think of all these issues. But if you do it under direct observation and you are clear that you are in the amniotic fluid, the only explanation in most cases is because the sample is taken long to get to the laboratory, because we put them in a container without any preservative. The preservative is the amniotic fluid itself. So they need to get to the laboratory on time so that the cells do not die. So this is the most common reason for no culture failure, cells dying in the process. Right. So I think, right, let's talk about these cutoffs which the laboratory sometimes reports. Because we are using a laboratory from another country, which probably may be using a risk cutoff, which is different from us. The risk cutoff is always sort of changing from the results I get. For example, in this case, you can see they are quoting the detection rates at a risk cutoff of 1 in 300 here. So that this patient who is here, who fortunately, after everything has been put, because we do the nasal bone, the ductus venosus, if we had used only the maternal age and the NT, this woman will probably be classified as high risk, according to this risk cutoff here, which the laboratory is reporting. But I've already explained how these risk cutoff mean, what they mean, how do people arrive at, and that we are using a risk cutoff of 1 in 100 to cancel the women that we say. So this woman was overly low risk, because after the laboratory put in everything, she came back with this result of 1 in 15,000. Like I said again, we look at this last line, Because this last line is putting in all the variables that we use to calculate the risk for aneuploidy. It is important to add these other markers because they modify the risk so much, as you can see there, so that we reduce the number of invasive testing, patients who need invasive testing. The newer tests, the cell-free DNA test, how is it reported? So this is one of our, okay, good, I didn't put identifiers. Good. So this is one of our patients again. She was 36 years old, fetal gender. The patient didn't choose to know the fetal gender because the patient has to choose or not. Normally they put an additional charge for fetal gender. So the patient didn't choose the fetal gender here. So it was not reported. If it was reported, it was going to be reported as an XX or XY, the fetal gender. Then the low risk, then all the results of the fetal self-reading test, they have to quote the fetal fraction because the interpretation of the results are so much dependent on a fetal fraction. The fetal fraction has to be at least 4% for the results to be valid. If they are less than 4%, then the interpretation of this result becomes very difficult. So in this case, they have to supply you the fetal fraction. They have to tell you what the fetal fraction was. What we mean by fetal fraction, we are saying it's not only the fetal cell-free DNA test in the maternal blood, there is also the maternal cell-free DNA test. So we're saying the proportion of the fetal DNA to the total cell-free DNA, that is both the baby and the mother's free DNA, it was 13.5% in this case. So this is how they report. Low risk, risk before the test. This is the a priori risk. If you remember the a priori risk, which we mentioned, which is more of age dependent, which we mentioned on the first slide. So this is the a priori risk of the woman before testing. So if it is low risk, all the results of the fetal cell-free DNA test will come back as 1 in 10,000. They don't give you the specific number like the combined test. So the moment you see this 1 in 10,000, 1 in 10,000, 1 in 10,000, this is how the fetal cell-free DNA test is reported. It doesn't matter whether it's whether it is tri-screen, whether it's panorama, harmony, they report it this way. If it is high risk, then it is going to be reported as greater than 99%, greater than 99% for any of these trisomies. Then, of course, the vanishing twin, you have to mention the vanishing twin or the risk so that they can tell you the risk for triploidy. Some of the tests are not good at picking triploidy. Then second trimester risk calculation. Sometimes we do get patients who will be reported as high risk or intermediate risk. The invasive test or further test from their doctors, then they are referred to us to say, can you please assess this patient? Their risk was this in first trimester aneuploid screening. Then what is what I want to answer? You say, when you refer the patients and say this patient was intermediate risk, was sort of high risk, or did not do the screening at all. We get this patient say, may you please see this patient? They didn't do the screening, but I'm just worried that this baby may have Down syndrome because the woman is 42 and she didn't do the screening. What do we do with them? So first of all, let me come to this slide, then I'll go to the other one. We have what we call soft markers of Down syndrome. Which are the soft markers? We have knuckle fold thickness. It's not the same as knuckle translucence. Of course, knuckle translucence can evolve to knuckle fold, but it's not one and the same thing per se, but one leads to the evolution of the other. So we have knuckle fold thickness, we have short humerus, we have short femur. These are not independent of each other. So when both of them are present, we only use one because they are dependent of each other. Then hydronephrosis, we have echogenic focus and echogenic bowel, and of course, a major defect. So when patients come to us, we look for these markers. Some of them, I didn't list them here, like choroid plexus cyst, I didn't list them here. And also shorteners are born. They should also be here. So what do these markers do? The studies that were done by these guys here, they looked at the likelihood ratio of having either trisomy 21 when these markers are present. And the likelihood ratio of each isolated markers were calculated. And we do have what we call the positive likelihood ratio and negative likelihood ratios. How do we come up with positive and negative likelihood ratio? We are saying we are going to compare the number for positive likelihood ratio. We put the number of babies who actually have Down syndrome and have this marker divided by babies who have this marker but do not have Down syndrome. Then we have the positive likelihood ratio. Then it is opposite for the negative likelihood ratio. So when we come across one of the markers, we are going to, for example, if we note that the baby indeed has hydronephrosis, how are we going to modify the risk from the first trimester? We are going to multiply this risk. If I just find hydronephrosis and I don't find all these other markers, so I'm going to multiply 6.77 times the negative likelihood ratio of these markers I did not find to get the overall likelihood ratio, which I will multiply into the risk from the first trimester to get what you call an adjusted risk from the first trimester. If my adjusted risk is high enough, then I can offer the woman an invasive test or a fetal self-return test, depending on the risk. I'm going to demonstrate this on the how we do it. I'll just leave screen sharing to allow me to share another screen in a second. Sorry, second trimester. Just a second. I want to share with you another screen briefly to just demonstrate the calculation, how we modify the risk for second trimester. Just a second. Let me go to my screen. Sorry, my computer crashed. I didn't realize it has closed some windows. Second trimester. Right. I'm almost there. Right. So I think I can now share my screen. Where am I? Right. So I will share this screen. Right. So let's assume that a patient has come to us. Let's assume the initial risk. When the patient had the first trimester scan, their risk was reported as 1 in 150 there. And the laboratory called you or called the patient as they are now doing. Let me adjust here. It should be 1 in 50 here. Right. Right. So 1 in 50. Right there. Should be there. Right. So let's assume that the patient had an aneuploid screening in first trimester, and the risk was 1 in 150. But this patient is averse and saying, I cannot go to see if I really need to go for an invasive test. So when they come to us, then we scan them. We see that there is ventriculomegaly. So when there's ventriculomegaly, I'm going to put a 1 there. Then when I put a 1, because the ratio of an isolated ventriculomegaly is about 1, it doesn't modify. Just a second, let me delete here. I don't know why my calculation is refusing to work. It should work. What's happening now? Let me just close it and reopen it. Sorry about this. Sorry about this. I just need to reopen it so that it can work and demonstrate what I have to demonstrate. Right. So, okay. Don't know why it is saved it now. Right. Just a second, I'll share with you the screen just now. I just want to resolve some technical issues which are happening with the calculator. Right, I think I'm good to go now. So let me share the screen one more time. So right, so let's assume that the risk from the initial screening was probably 1 in 1,200, and during the anomaly scan, it happened that I've picked up some soft markers. Let's say I've seen that the nuclear fold is increased. I'm going to put a 1 there. I want you to look at what will happen to these figures. So when I put a 1 there, don't know why it's not calculating. Then let's put a 1 there. Oh, my calculator has just failed. Probably from I don't know what has happened to the original copy. But what it does is that it's going to modify the risk for us and show us an adjusted risk. So if that adjusted risk is now less than 1 in 100, what we are going to do is we are going to re-offer the woman the invasive test and tell her that, look, your probability after doing the scan is actually becoming higher now. The risk of you having a baby with Down syndrome, and the woman has to make a decision whether she wants us to proceed and do the invasive test or not. But we are going to modify the risk depending on the markers we get. The more the markers you get, the higher the likelihood ratio is going to change. I don't know why my calculator is misbehaving. It works very well, but maybe it's because I'm presenting. Somehow is misbehaving, but it's supposed to change all these values and show us what the new risk will become. So this is how the risk modification is done using the risk reassignment in second trimester. So women who come for a second trimester evaluation, we recalculate their risk and we reassign their risk, and their risk changes. What happens to women who come to us and they have a high risk result for aneuploid in the second trimester? Normally, those women, we do offer them invasive testing, amniocentesis, instead of the fetal self-readiness test, especially if they have already done the first trimester. One of the reasons why we offer the invasive test is because to avoid the delays. Normally, if you don't offer them the invasive test and you offer them fetal self-readiness test, it takes 2 weeks to get the results. But if they come back as high risk, you still have to offer them an invasive test, which will take another 2 weeks. By that time, they'll be probably 26 weeks or 28 weeks, and they may need a feticide for fetal termination, which is more traumatic than just terminating a pregnancy, which is before viability. I think this is the end of my presentation. I did not present on exome sequencing or chromosome array results because we have not done any or received any in our country yet. But when these results start coming in, we'll begin to discuss with about these results. Thank you so much. I think this is the end of my presentation. I will hand over to the chair for questions.
Thank you, Dr. Verenga, for that very informative talk. I think it has explained a lot to most of us who were requesting these tests and were not able to interpret them. Are there any questions currently for Dr. Verenga? Can we have questions for Dr. Verenga? Or comments at that? Questions or comments? Was it that clear or was it that unclear?
Maybe it was very confusing. I think there's a chat. Okay. So say thank you.
It's now 9:06. If there are no questions, queries, comments, anything at all, I think we're going to call it a day. And maybe we need to just go and look at what we've been told by Dr. Verenga. We might have questions next week. So if we have questions next week, please feel free to raise them up next week. Again, this is a recurring meeting which we have every morning between 8 and 9. Please feel free to join us at the fetal medicine unit. Currently, we are doing a series on diagnostic tests. And today he shared on how to interpret them. Thank you all for joining us.